discussing about the journals to this month, and there are quite interesting articles which have come with regards to a mixed bag in pediatric endocrinology. Why really do we need to do a literature review? That is a key question which often we will ask, and often if we do not look into the literature, we will be left behind in terms of what new developments are happening. So the 4 points we want to look at in a paper which is coming is it valid? Is it generalizable? Particularly if it's been done in a different environment, is it valid and generalizable for our population? Is it a novel work which warrants a change in our practice? So this is what are the 4 criteria that we'll try to assess all the 4 journals and try to see if we need to change our practice from that perspective or not. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of innovative resources and courses. We have got fellowship programs and diploma programs in pediatric endocrinology. There are 3 programs which we run every month. One is a grand round, then this is journal club, and then we've got a PG lecture series which is run from that perspective. There are publications and mobile applications. We all know that obesity in children is increasing day in and out, and a lot of complications are happening right now, along with the increased risk of cardiovascular complications which happen subsequently in life. So we'll go into the 4 key issues. Why was this study done? How was it done? What did they find? And whether it should change our practice or not. These will be the 4 questions. We will go on to that. So now we all know that obesity is a major challenge now, and we are seeing a lot of obesity complications in young ages. The Endocrine Society guidelines show that if we are able to cut down on BMI, we are talking about reductions in systolic blood pressure, triglyceride levels, along with improvement in the metabolic profile. So it's not just about long-term complications. The short-term complications will also improve if we are able to do a good control in terms of BMI. Now, what we really want to achieve in our obese child or adolescent is stabilization to begin with. We don't want a massive weight loss. We want approximately 7 to 10% loss in weight. Now, you can say it in forms of weight or in form of BMI. That would be the sort of loss we're talking about. Less than 1.5 kilogram per month. Our overall loss of approximately 10% in BMI standard deviation score is what we want to achieve. Very importantly, if a child is growing normally, we would expect the BMI SDS to come down gradually over follow-up. We don't need to have dramatic loss in that perspective. Now, what options do we have in terms of obesity? So when we're talking about obesity, it's basically an imbalance about how much we are taking in and how much we are spending. So we can either focus on the ventromedial hypothalamus, which is a key regulator of satiety, or we can talk about resting energy expenditure. Now, most strategies are focusing more in terms of reducing calorie intake rather than increasing expenditure. And that's important because most of them have not been found to be very effective. So theoretically, we can inhibit the lipase enzyme, which will basically allow the loss of fat in the stool. So this is how orlistat works. This is one mechanism which is approved beyond 12 years of age in children. We can use metformin, which can cause peripheral sensitization and growth hormone in certain subset of patients like Prader-Willi syndrome. But these medications are not anti-obesity medications. Metformin is specifically recommended for children who have got type 2 diabetes, but not other indications. So we need to consider it's not an anti-obesity medication. Growth hormone only in individuals who have Prader-Willi syndrome shall we think of it as an anti-obesity medication. The other option, of course, which is quite attractive is the use of GLP-1 receptor analogs. Now, we all know that GLP-1 is an incretin, which is secreted in response to intake of carbohydrate from the duodenum. It has got 3 major effects. One is to reduce the satiety at the level of the ventromedial hypothalamus. Second is to prolong the gastric emptying, along with increased insulin secretion. And insulin is also something which induces satiety. So in a way, if we use GLP-1 receptor analog, we will be able to achieve a good amount of satiety, bloating, reduced food intake, and there will be improvement in terms of weight. The other option could be that if we can block the somatostatin pathway using octreotide, this again is a very specific therapy for hypothalamic form of obesity, not for other forms of obesity. In individuals who have leptin deficiency, leptin replacement has been used, but again, very specific and targeted intervention. There is also studies about the use of MC4 receptor agonists, which is setmelanotide, particularly for POMC deficiency and leptin receptor defect. So these are areas. And now, interestingly, there is a monoclonal antibody which has been developed against activin, which increases the muscular activity. So these are the broad drugs which are being used. Now, what drugs are approved for use in adolescents, Dr. Manoj?
The GLP-1 analogs has been approved.
Okay.
Metformin has approved, and setmelanotide.
No. So most important, of course, approved is orlistat. That is the drug which is approved for long time. Now, metformin is not approved for obesity treatment. It is approved for type 2. The other drug which has recently been approved is a daily injection of liraglutide, 3 milligrams daily. And recently, phentermine combination with topiramate has also been approved, but this is a centrally acting agent. So there are 3 agents which are approved currently for management of obesity. Now, what we are seeing is that most patients who come to us with obesity have a BMI standard deviation score of approximately 2.5 to 3. If you want to have a meaningful reduction, you're talking about a fall of approximately 0.5, which is pretty high and difficult to achieve. So we'll see how much do we expect with these medications. Now, orlistat, of course, is a medication which is basically working in terms of improvement. And this is a study which was a trial. This is the only trial which is available for orlistat. What we see that there is a reduction which happens in terms of the BMI. Now, what you're seeing here is that there is a reduction, but we are talking about BMI points of approximately 1. So the maximum reduction is happening is 1. So when you talk about 1, we are talking about 4 to 5% reduction in BMI. So if somebody has a BMI SDS of, let's say, 2.5, and you're reducing it by around 0.1, it is not going to make a huge difference. In terms of weight, again, if you see the weight loss is only 3 to 4 kilograms, so it's not going to be hugely effective. The problem with orlistat is also that there will cause gastrointestinal symptoms, bloating, it will cause steatorrhea, leaking, and all the other problems happen. So this is a drug which is not very effective. And what is recommended is that if you do not see a benefit in the first 12 weeks of treatment and the reduction in BMI SDS is less than 5%, this drug is not going to be more effective. You should stop at that point of time. So this is not something which is very helpful. Now, phentermine topiramate is the second group of drug which has been recently published. This data is from 2022, particularly in children. And what we are seeing here, and this is the percentage change of BMI from baseline. Now, they had used a mid dose, a lower dose, and a higher dose of phentermine topiramate. Now, what you can see is that the higher dose is causing a reduction of approximately 10 to 11%. So this may be a reasonable reduction that you can talk about. So 10% reduction. But the problem of these drugs are that they are all centrally acting, and that the history of centrally acting drugs has been very bad. Many of the drugs had actually had to be banned and removed because they caused depression, they caused suicidal tendencies, because this is the same area that you have the reward area and the other hypothalamic area. So rimonabant, sibutramine, a number of drugs had actually to be removed. So we would be very cautious in using these drugs in adolescents. So this is something which has been approved, but most people are not using at the moment in terms of pediatric age group. Now, there's a reasonable benefit, but this is a centrally acting drug. Now, what about the use of GLP-1 receptor analog? Now, liraglutide, as Dr. Manoj was saying, is approved beyond 12 years of age based upon this study published in NEJM. And what you can see is the change in BMI standard deviation score. So the minus 0.3 is the rough change in BMI standard deviation score. So what we are looking at here is that this would be somewhere around 10%. So 10% decrease will happen in this figure. But what's very important is once you stop the treatment, what is happening? There is again an increase which is happening towards the end. So there is a rebound phenomena which is happening. So this has been approved, but there are issues that you have to give a daily injection of 3 milligrams, which itself is a problematic issue. You need to have a patience because the effect is not too much. And then there is a bounce back which happens also on follow-up. So all the 3 medications which are FDA approved for management of childhood and pediatric obesity are not up to the mark in terms of efficacy, in terms of durability, and in terms of ease of treatment. So we have to think of options which are there in that perspective. That brings us to this new molecule, which is semaglutide. Now, many of us are aware about the oral preparation of semaglutide, which has been approved for the use in adults. But what we're talking today is the injectable preparation of semaglutide, which is to be given once a week. This preparation is unique because it has got specific alterations in the amino acid profile to allow decreased degradation by DPP4, having anomalous fatty acid binding, and the fatty acid binding then will bind to the proteins, reducing renal clearance. So overall, the half-life of GLP-1 will become more. And this allows administration in a week. So this is a good preparation, once a week preparation, definitely going to cut down the number of injections and maybe more favorable in that perspective. So this drug is being used and it has been tried in adults with obesity. Now, if you look at the adult picture, the change was approximately 16%. So this is a substantial increase. We're talking about 5%, 10%. This is 16%. Now, 16% would mean that if somebody is at 2.5 standard deviation score, roughly you're talking about that they will come down to around 2. So this is a reasonable decrease and they're coming down to a different category altogether. So this was a good drug to look at in terms of adults. Now, of course, we need to have evidence which is there in terms of the adolescent population in that perspective. So now we know definitely there is a need for a new drug which can improve the outcome with better effect without causing adverse effects. So now how did they go ahead with this study? So the design of the study was a very elegant design. It was a randomized, double-blind, placebo-controlled, phase 3A, multi-centric trial. So it's a big trial overall in the globe. They had 37 centers, and this was pretty much around the time of COVID. So you had presented last time about liraglutide and Prader-Willi. So I think simultaneously this study was also going on of weekly semaglutide in specific obesity population. So that was a big problem about COVID around that time. Now the analysis in this case was intention to treat. Now what do you mean by intention to treat analysis, Dhwani? Vibha? So intention, Manoj? So when you say intention to treat, it basically means that you will assume that if a patient has not taken the medications, if the patient has taken it only for a week or a 2 week, you will include him in the treatment group. So you get the point? So that it is not happening that you may actually ignore those patients. Maybe somebody lost to follow-up or somebody is not performing well, you will say, I will remove that patient. So intention to treat is a very specific way which ensures that every patient who is enrolled in the treatment arm will be considered in the treatment arm, irrespective of the treatment. So if he discontinued the treatment and he had a bad response, he will still be in the treatment arm. So this is a very, very important parameter to look at as to how the study was formulated. So intention to treat means that they are actually looking at a real world sort of a thing also. If you've lost a follow-up, what happened with the weight becomes important from that perspective. So individuals from 12 to 18 years who are obese or overweight with complications. Now, I would be very wary of giving anybody who is overweight injectable preparation. So there was only one patient who was actually there. Maybe they wanted to get more samples. That's why they were a bit scared. They added overweight. But overall, only one patient was overweight. So it's mainly obese individuals that we are talking about. And they should have had a documented weight loss attempt, which was unsuccessful. The exclusion criteria were, of course, that if recent changes of weight was more than 5 kilograms, if they had received a medical treatment for obesity in the last 90 days, of course, if they had undergone a bariatric surgery, because bariatric surgery will impact the GLP axis in a big manner. That's another thing. Any condition which may alter the response, depression, secondary causes were also excluded from there. There was a run-in phase in which 12 weeks they had to educate everybody about lifestyle, physical activity, and then they went on with the intervention in that regards. There was a behavioral intervention as well. Now, this was a randomized trial and they used 2:1 ratio. So there were 2 treated patients versus 1 placebo in that regards. And they were randomized as far as the gender and puberty status. All of you should go and look at the way the study has been designed, and they are mentioned because they are very nicely put forward what the ideal study should be. So they had specific techniques about randomization as well. The treatment here was semaglutide was started at the lowest possible dose of 0.25 milligram per week, and then was escalated over a 4-month period to 2.4 milligram per week, or the maximum tolerable dose. So again, first 12 weeks was more like titration or allowing. And this happens with most GLP-1 analog. If we talk about the Trulicity injection, if we talk about Rybelsus, we start with lower doses and build it up to allow GI symptoms. The duration was 68 weeks, and this 12 weeks was the initial phase plus 56 weeks from there. And then 7 weeks they followed up without treatment. So overall 2 weeks of run-in period, 12 weeks of building up the dose, 56 weeks of actual treatment, and 7 weeks subsequent. So it's a big follow-up data which is there. And when I'll tell you that there was a retention rate of 99%, which basically tells us that they were able to really follow up very well in terms of their data, and they had hardly any loss to follow up. So if you have intention to treat, you don't want to lose anybody to follow up, because that will be a bad outcome measure also from that regards. Now, what would you like to look at in terms of efficacy? The obvious thing would be is how much did it make a difference in terms of BMI? So their primary outcome measure was a percentage decline in BMI. The secondary outcome measure was those individuals who received a 5% or more decline in weight. So there were their two major outcome measures. They also looked at the other parameters like BMI, SDS, weight, waist circumference, HbA1c, ALT, lipids. So a lot of other parameters were also looked at. But the study was powered mainly for percentage BMI decline. So this is another message. So when I talk about the numbers, the number was such that 90% power was there for the BMI decline. And for weight decline, the power was 71%. Now, what I'm trying to say is that they were less powered to identify a weight decrease. Now, if they find a weight decrease, what does it mean? So their power was 71%, but if suppose, and we'll talk about when we talk about the study, Vibha, is that if they find that there was a decrease in weight, do you think this is right, or they were underpowered, or what was the significance? Manoj? So they were not powered to 90% to find a difference, but they found the difference. It means that there is a huge difference. Suppose you are supposed to have spectacles of, let's say, +2 to get a vision. But even at +1, if you're differentiating between the two, there has to be a bigger difference. So even at lesser sample size, if you're making a difference between the two, the difference is huge. If you do not find a difference, then you can say, okay, I was underpowered, and maybe if I had 200 people, I might have picked up. So power is more for missing out. But if your power and you are still identifying the difference, that becomes significant. So this is important. So remember, 90% power was mainly for primary. This one was underpowered, but whether they found a difference, we'll talk about that a bit later. They, of course, looked at other things like quality of life and safety, very importantly, predominantly GI symptoms, heart rate, pancreatic issues, calcitonin, because theoretical concerns about medullary carcinoma, thyroid, other things are also there, which you have to be worried about in that perspective, and mental health. But the key thing to look at was how much did the BMI come down? That was their crux of the entire assessment. Now, this is the baseline characteristic, not much to look at. The mean age was pretty much in the adolescent age group, 15 years. So this will be the typical age group. What we are seeing also is that most patients were in the late puberty stage. So of course, adolescent, we're talking about that age group. The BMI, so most were late pubertal. The BMI standard deviation score was approximately 3.3. So there was a significant obesity. So they have told overweight, but only one child was overweight. So it was pretty much obese. But if we look at our obese adolescents, they will be similar to the same age group and in terms of BMI. High levels of obesity, and 4 patients were diagnosed with diabetes. Now, in diabetes, if they were just being managed by a metformin, they accepted the patient. Otherwise, they did not. So 4 had diabetes associated, which was picked up on follow-up. And this is a big study. We're talking about 201 individuals. out of which 2/3 were given treatment and 1/3 were given placebo. It was a double blind, so nobody knew which is the preparation there. Now, next step is what did they really find? And if you look at the primary outcome measure, what you can see that placebo, pretty much there was hardly any difference as far as the BMI is concerned. But this is an impressive decrease of approximately 16% in terms of BMI standard deviation score. But what I'm seeing there is that there is an upclick, which is again happening towards the end. So remember the figure that I was talking about in terms of liraglutide in adolescents, there was a huge resurgence after that. This follow-up is less, but within 7 weeks, again, there is some regain happening, but still there is a substantial difference. The other thing to look at that out of 134, 131 were there till 68. So it's a huge issue in terms of compliance was very well maintained. Placebo 67, 62. So good numbers were there throughout the study and they use intention to treat analysis. So there is a dramatic decrease in terms of the BMI. Major difference happens from 12 weeks. There is a plateau probably happening beyond 52 to 68. So probably after this, you don't gain much. But this is the big question, what happens after you stop the treatment? Whether they had a rebound, this will be an important factor. And the second parameter, as I said, how many of them lost weight of 5%? It was 73%. Then 62% lost 10%. And at 20% also 37 people had 20% weight loss. So somebody who was 100 kgs lost 20, become 80. So this is a big message. And in the placebo, of course, this number was very, very small. So there is a good decrease in terms of BMI, a good decrease in terms of absolute weight loss. So both primary and secondary outcome measures are there. So now what I was saying that the power was less, but if suppose you have to compare an elephant and a rat, you don't need any power. You can say one sample, you can make a difference. If you're comparing two different types of horses, maybe you would need much longer type of sample. So here the difference is so huge, you don't worry. Even if your sample size was 15 or 20, maybe you might have found this difference because there is a huge difference there. So this is the understanding of power that you come from this study. Now this again is talking about the change in BMI. So what they are saying is that more than 20% reduction in BMI was found in 40% cases. So this was again a huge. So there was a good benefit which was there, while here the numbers in placebo was much, much lower in that perspective. So if you look now, the change in BMI is minus 16.1 versus 0.6 plus. So there is a 16.7% decline in BMI differential in that perspective. There is also that 73% children had a weight loss of more than 5% versus 18% in the placebo. There is also a decline of around 1 standard deviation score. So remember, we said 3.39 was to start with. So again, 20-25% reduction in terms of BMI SDS. Compare this to liraglutide, the figure was much lower. Compare this to orlistat, it was only 5%. So there is a substantial decline that you're seeing. 15 kg loss, average weight loss versus 2 kg weight gain. So good amount of weight loss. I will be happy with that. If you talk about bariatric surgery, the typical weight loss is around 20 to 30 kg. So this is a good weight loss. So we are talking about a year and you're losing 15 kg. So I'll be happy with that. I'll still be concerned about the up. So we need to have more data in terms of follow-up. Now, if you look at other parameters, that this is what it shows, that there was a decline in BMI from around 28 weeks, around 6 months to 1 year was the peak time when you have a good response in terms of BMI. And same was true for the body weight again from that perspective. Now, if you look at other parameters which were there and they looked at waist circumference, there was a substantial decrease in blood pressure, marginal decrease, also some decrease in terms of ALT levels. So this is important. We know that these groups of medications are good for fatty liver. So there is a 20% reduction in ALT levels which were also noted in that perspective. So overall, it seems you're coming down on BMI, you're coming down on weight. So of course, comorbidities will also come down in that perspective. Now, what about adverse effects? So of course, the main adverse effects were predominantly in terms of the gastrointestinal. 4 individuals developed a gallbladder stone. So you have to be careful about if these patients complain of pain, it's not just acidity or bloating. Get an ultrasound to look at a gallbladder stone, whether it is there or not in that perspective. So gastrointestinal symptoms were predominant. Others, there was not much difference in that perspective. So now whether this study should change our practice or not is the question. So the authors conclude that there was a good response to 2.54 milligram weekly in terms of response. All other parameters, complications also improved. And what they said, that their findings were consistent with other studies in adults. So which seems reasonable that we have got a good response in that perspective. The important observation was that the reduction was much more compared to other drugs. We talked about the combination of topiramate. We talked about the liraglutide or orlistat. The response is better than this. And their percentage point was approximately 17.4. And they said that their 60 weeks seems to be the good time. So as I said, 6 months onward, there is a response. 1 year is the best time when you get the maximum response. So how long to treat? That will probably give you the answer from there. Now, there was also improvement in the quality of life and other parameters. They do write a bit about the rebound weight gain and whether this will happen. And they say we need to follow up more on that perspective. So if we now really judge that, this is an excellent design, prospective randomized trial. Intervention is very clear, very well monitored. Population also is the same that we see obese adolescents. Subjects were definitely generalizable. Intervention is feasible and hopefully it will be available also soon because based upon this, they have applied for the FDA approval. And the impact is a good impact of 16%. So this is a positive study overall, which talks about a novel way of managing diabetes. I'll be happy if there is a 1 year reduction of 15 to 20 kgs in a child who is 100 kgs. And this will, of course, cut down on complications. So we need to watch the space as and when semaglutide is available. Now, oral semaglutide is available already. Now, next step would, of course, be to think that in the treatment of obesity. So that will be the next step. And then it will make life much easier rather than injections, because injections will be the new thing. So just to summarize, we have got a novel option which is available, which has an impact on gastric emptying and satiety. So now we have had discussions about 4 very important topics. One was about the use of a novel drug for the management of childhood obesity. Then we talked about the effect of maternal thyroid dysfunction on outcome of neurodevelopmental. We talked about the various parameters, and what we found was that it may be good to actually stick to a fasting PP and HbA1c rather than go ahead with other parameters. And CGM initiation at diagnosis would be a good parameter. All of you can go and have a look at our website, the courses, and the mobile application.